Hi, my name is Rohan. I work with Quicksand as a design researcher and strategist. For over a year now, we've been working quite closely with this emerging community of practice called CoreNet. Today, we are here on the second plenary to learn and talk and discuss a little bit more around frontline workers, to talk about how we've seen them take responsibility in the past year, and what are the emerging immediate needs, and how do you balance that with long-term system requirements. Very quickly, I'll go over the ground rules, and then I'll pass it on to Dr. Preethi, who will be moderating this discussion. We are recording this discussion. You can speak in Hindi or English, and we'd be able to translate that for you on questions in chat. There is a Q&A box for your questions, and you can ask or share comments. Use the chat box for your comments. It'll be great if you can introduce yourself and add the name of your organization, because that helps us place your question better. We're also live tweeting this session, so if you are doing the same, please tag us at CoreNet India, OPM Global, as well as hashtag CoreNet Conference. And lastly, a really important thing that we thought we would share with you, and it's just that it's taken us a lot of work and reflection to even think about canceling the conference many times, etc. It's been a really difficult time for so many of us. The pandemic seems not in a recovery phase. It's right here, and it's touching so many of our lives. We are deeply grateful that not just the audience, but also the panelists could be here with us at this time. Everyone's feeling vulnerable, but at the same time, everyone's taken this time because we feel like this conversation is important. So just keep that in mind when you're engaging with each other and the panelists. We're all here to learn. So please listen with curiosity and speak and write with kindness is our request. And with that, I'd like to now just introduce Dr. Preethi John a little bit before I pass out to her. Dr. John has an experience of over 25 years in the healthcare sector, and she's worked with LICO, with Arvind, the eye care system, and she spent the past decade building up the Chitkara School of Health Sciences as its founding dean. Her areas of consulting, research, and teaching are building the capacity of human resources for health through curriculum design, health system resilience, and building through community initiatives, gender transformative leadership in healthcare, and technology-based interventions for healthcare education. Yeah, there's much more to cover in this session, but for all of that, I will now pass it on to Dr. John.
So in this webinar, we will be focusing on the frontline workers' response and management of the COVID-19 situation, the challenges, and aims to initiate a policy dialogue to devise programmatic solutions to strengthen system preparedness for emergencies, crisis situation management in the future, as well as ensuring continuity of regular healthcare services. Let me take a moment to introduce our esteemed three panelists. We have with us today Dr. Sonia Trikha, Director, Health Services, Haryana, where she's also serving as the Executive Director of the State Health Systems Resource Center and the Director of State Institute of Health and Family Welfare. We have Bhanupriya Rao, founder of BehanBox, a digital platform for gender journalism. She's been an independent researcher, journalist writing on gender, governance, and social justice. We are also have on the panel Dr. Tanmay Mahapatra, who leads concurrent monitoring and learning, CML, at Care India's Bihar Technical Support Unit. CML is a structurally embedded but functionally independent large unit designing several operational and transnational research studies for informing public health program implementation, translating research, and generating evidence to help policy making. And before we start the panel discussion, I would like to invite Dr. Deepika Saluja to set the context for us. Dr. Saluja is a consultant with Oxford Policy Management India, where she is responsible for documenting partners' engagement in COVID response and synthesizing evidence on the pandemic. She also leads OPM's engagement with COVID Research Network on Frontline Health Workers Working Group and the OPM Women in Global Health India webinar series on frontiers of thinking and evidence for the community health workers. She's also one of the co-founders of the WGH India chapter. Over to you, Deepika, for context setting.
Thanks a lot, Preeti, for this warm welcome. Thank you, everybody, and a warm welcome, everybody, for joining us for this interesting panel discussion. So I'm going to spend the next 10 minutes or so reflecting on the findings and issues that have emerged strongly around the engagement of FLWs in COVID response in the research studies that were conducted as part of the thematic working group by its members over the past 1 year. So to begin with, a quick scan through the news articles consistently have reported the concerns and challenges of the community health workers, with particular focus on the voluntary cadre of health workers, that is the ASHA workers, the strikes that they did in the month of July, asking for the demands for better pay and protection, and other concerns and challenges that they have been facing while responding to the pandemic on the ground. We see ourselves actually the same situation a year later with an exponential increase in the COVID cases, the challenges that we are facing with the vaccine delivery, and a crumbling health system that did not learn much from our experience of managing the pandemic over the past 1 year. So if we look at a quick snapshot of the disruption to FLW provided services, we see a huge dip in service disruption, particularly during the early months of lockdown. But by the end of 2020, we saw that these services restored almost to the pre-COVID levels. And now moving forward, we see that a similar situation is going to come back again, and FLWs are facing the surge and repeat of previous challenges. So the question then comes back to us is that how do we deal with that situation, and how do we engage FLWs effectively moving forward? So as part of the FLW thematic working group, we attempted to map the evidence and synthesize the findings from the studies that were conducted by its members, and identify the learnings and also the gaps that could help us identify the future program and research direction. The synthesis included 17 studies conducted by 14 organizations across 13 states of India, covering different regions, but majority of the findings came primarily from 4 states, namely Bihar, Jharkhand, Madhya Pradesh, and Rajasthan. The studies included have been conducted between the months of March and December 2020, with many covering different stages of the response longitudinally through different rounds. And the studies which are ongoing, covering the most recent impact on the evolving roles and responsibilities and changing situation on the ground, we are yet to hear back and receive the findings from those studies. In order to understand and contextualize the findings, we mapped them onto this framework of power relationships, which has been adopted from our resident anthropologist. And we saw that many of these study findings are either about CHW's position within the government health system that gives them resources and instructions, or CHW's position within communities where they work collaboratively with beneficiaries to get them access to the healthcare services. These power relations are interrelated. The working group research highlighted that those resources and status that is granted to the FLWs by the government system often determine how much they're trusted within their communities. These power relations are also about gender and the societal structures which are deeply rooted and hence need long-term strategies and continuous efforts in dismantling them. Some people argue whether CHWs are empowered or disempowered. They actually have a lot of self-efficacy and they use discretionary power, but they are also hugely constrained by the system level resources and the authority to take decisions. looking at different types of power shows that both could be true at once. So one type is like unequal power over, which constrains and dictates. Other types are power within and power to, the capabilities and the self-efficacy that CHWs have within themselves. By themselves, and a central type for CHWs is the power with, the capabilities that they get by working in partnership with other actors and beneficiaries. So the call to empower CHWs for better performance is related to the rights-based legitimate source of power. It does not negate the discretionary power or the existing self-efficacy that CHWs already have, and hence it shouldn't be confused with that. So next slide, please. We go over each of them one by one, starting with the resource constraints and the power over. With the already resource constrained health system, we saw that the impact actually got magnified during the pandemic, and given that all the resources were being redirected towards pandemic related activities, that severely impacted the delivery of essential services. For example, the supply of PPE kits. So the PPE availability was reported to be consistently a consistent challenge across different states, putting CHWs in a vulnerable position during field visits, during their surveillance activities, during delivering healthcare services within the facility, along with the concerns over, for example, poor quality or size or fit of the PPE kits. That these issues were also reported. Then facility-based CHWs reported that there was skewed allocation toward allocation of these PPE kits towards doctors, nurses, and other permanent staff as compared to the outreach workers. Further, mobility restriction disrupted supply of vaccines, essential drugs, and delivery of ration. With everything moving to online mode, and given the country's digital infrastructure that limited FLW's access to training, smartphones, and internet connectivity. There were also reported delays in payment and lack of clarity amongst these cadres on the additional benefits or incentives that were promised, insurance coverage, the benefit, their eligibility, etc. And with the slow resumption of essential routine services in the later months of lockdown and early unlock phases, CHWs reported increasing workload and having responsibilities for both COVID and non-COVID related tasks. And while facing these challenges, to meet these additional responsibilities, many CHWs reported receiving little support or training on ways to manage these, potentially leading to situations of distress and anxiety and exhaustion. For example, one of these studies reported that 59% of the ANMs interviewed reported higher stress levels than normal. And these are, it was, to recall, the study was conducted in the months of July, around that time. And at that point of time, these issues around mental health and the need for psychological support just began to emerge. Further, CHWs across the studies also reported adapting to the situation, given the resources that they could mobilize at that point of time. For example, using WhatsApp messages and calls for conducting outreach activities, for doing follow-ups, for reporting to their supervisors and sending updates at the end of the day, or producing masks locally in the times of short supply, or assisting other CHWs in delivering take-home rations and helping the community members actually to get the ration cards who did not have. As I mentioned, that there were reported cases of CHWs feeling overwhelmed and exhausted because of the increasing workload. This also came with reported cases and incidents of stigma and violence and discrimination that were faced by from the community members. And instead of being appreciated as the warriors, they were by many communities being labeled as the carriers of Corona or Corona Didi. And all this had implications on their own mental and physical health, which has now slowly begun to emerge in the more recent follow-up studies or ongoing studies. And on the other hand, some CHWs also reported receiving support and encouragement from their supervisors, given the shift in online mode, and then that they were able to reach out to their supervisors more frequently through WhatsApp messages and calls. For example, a CHW shared that her supervisor was like a mother to her, who supported her and mentored her to respond to the situations better. Next slide, please. Lastly, as part of the community response, we observed a shift in the community response towards FLW engagement, beginning with a great sense of fear and uncertainty in the initial months of lockdown, which slowly reduced, and instances of support from the community members towards FLW started to emerge. But on the other hand, there were also cases of reported resistance from within the community, as you could see from the quotes. While CHWs were considered to be one of the most reliable sources of information for the community members, there were some other cadres within the community. For example, the SHG women and the PRI leaders, the elected women representatives, they also emerged as another critical support within the community who were complementing the CHW's work on the ground. And reflections and recommendations came along, integrating the work of these community collaboration and deliver the services on the ground. And lastly, CHWs were reported being reached out by the community women for advice on domestic violence related cases. And for example, and they also reported that given the limited counseling skills and training to handle such kind of sensitive cases, they reported themselves suggesting or recommending these women to stay silent or not react or not report. And this could have serious implications on the physical and mental health of the women themselves in such situations. So this emerged as one of the critical areas that needed immediate attention. With this very brief context setting, I mean, basically we wanted to provide a quick snapshot of the challenges and issues that have emerged or being reported in the working and engagement of FLWs through these studies during the pandemic. We often hear a lot about challenges and issues in numerous sessions and webinars. So we thought that we might as well use like initial few minutes to set that context and give a quick snapshot of the challenges, and use the opportunity of having such an esteemed panel to collectively reflect on the way forward. Like what are the lessons that we learned from our engagement over a past 1 year and managing the pandemic, and reflect on how do we address the immediate needs and also the long-term system strengthening components. So with this, I would like to pause. Thank you very much for your patience, and I look forward to an exciting panel discussion. Over to you, Preethi. Thank you.
Thank you, Deepika. I think you kind of gave us a walkthrough over the ground situation over the last 1 year. Also, the consolidation of evidence that you and your team have and the CoreNet wider group have been able to put together. And this is so important. You brought out how on one side there is greater community awareness, perhaps even greater support for the FLWs. And yet a lot of evidence is there that power-infused relationship affects the FLW's effectiveness. As well as in times of pandemics, crisis, disaster, the ability for the FLWs to absorb shocks, that support system or the ecosystem also needs to be very much in place. So now we are not only back to that 2020 response phase with the exponential surge, but we've also got the whole vaccine delivery challenge. So let's go into this panel discussion by delving into this into greater detail. And in this round, we would like to reflect on the learning from the past 1 year of FLW engagement to understand what worked well in responding to the crisis. So if you look at this particular slide, there's a lot of coverage which is bringing out of how health services are hit. At the same time, the FLWs are trying to take work forward. So the first question I would like Bhanupriya to look at this. You have been doing extensive research to understand FLW's needs, challenges, working conditions over the past 1 year across multiple states in India. And as you reflect and think about, what the critical differences are, could you share with us and the audience the community perspective based on your reflection from engaging the FLWs, the positive adaptations with the Panchayati Raj institution leaders on the ground? Bhanupriya, over to you.
Everyone, just that we are in such extraordinary times once again, that this discussion becomes even more critical about what we have learned in the last 1 year of pandemic response and the role of community workers within it. And so when I'm going to talk about frontline workers, I'm essentially going to focus on 3 cadres of health, frontline health workers, really. Cadres that we have worked extensively with, the ASHA workers, the Anganwadi workers, and the auxiliary nurse midwives, of which Anganwadi workers do not necessarily come within the healthcare system as such, but they have been providing very essential sort of services as much as ASHA workers and others have been on the ground. And therefore, the whole systemic situation about them also needs to be looked into. But to your question, Dr. Preethi, I would what the 1 year has taught us in the past, in the last 1 year, what we have learned is that what the pandemic and its response really have done is that it has exposed the challenges of the already systemic challenges that exist within both our public healthcare system, as we are seeing it now, as Deepika mentioned in her opening as well, but also the situation of the healthcare workers within that public healthcare system. So, for example, when this is very whatever that in the last 1 year, a lot of common people even first came to know about a category of workers called the ASHA workers. Because that's how far removed we are from the essential healthcare workers that are not just, they are the backbone of our healthcare system, really. So what this pandemic has done is to amplify the existing essential inequalities and structural problems within the healthcare system and the situation of the healthcare workers within it. And why I say that is because, very strangely, ASHA workers are both a part of the healthcare system and yet they are not. If you look at it, they are part of the healthcare system in the sense that they are providing all the essential services. They are collecting all the data on which our response, our public health response, even in non-pandemic times exists. But they are really not considered as part of the healthcare system, both in terms of their rights as workers, but also in terms of how they are treated as healthcare workers, as Deepika mentioned in her opening as well. And this is where the gendered nature of the whole healthcare system and the healthcare providers comes into fore. What we also saw during the pandemic, and some of which Deepika did mention in her opening, was that this whole burden of single-handedly somehow being the first responders from the beginning, from March onwards to now, really, has been shouldered essentially by these healthcare workers whose rights are completely undermined and who are not even paid salaries. What they are paid are incentives. And what we saw during the pandemic was that these incentives, in fact, because these are task-driven incentives, these were not, because of the reduction of some of these tasks during the pandemic, their salaries or their earnings had dropped by as much as 50% in many of these cases, which led to a lot of them entering into a lot of debt burden. And I'm citing all these things because once again, we are back to square one, where if we are not addressing these very systemic challenges, and what we are instead announcing is these band-aid sort of systems where where the government is announcing 1,000 rupees a month as COVID incentive, which is again has not been paid for many, many months. And we did a study across 16 states where we found that in the middle of the pandemic, these ASHA workers were not being paid anything or these incentives in 75% of the states. And in many of the states, there has been a severe lag in that even their usual time incentives ranging from anything between 1 to 6 months. So these are some of the issues that we really need to look into when we talk about lessons learned from this pandemic, which is really rooted in the rights of healthcare workers themselves. So unless we are correcting these systemic imbalances, we probably will only be providing for what we will be providing for is a very band-aid sort of a solution, and not a long systemic one. In terms of your question about do we have any positive sort of experiences of cases which we can look into as adaptive measures. Certainly one of the things, and I think this has not been talked enough, that I feel, and I'm glad Deepika brought it up, but some of the states have had some of these really localized adaptive measures where, and states like Kerala and Karnataka, for example, and in some ways Andhra as well, where at the panchayat level, these were there were rapid response teams that were established, which consisted of ASHA workers, Anganwadi workers, and Panchayati Raj members, ward members, sarpanches, and so on, and other sort of local village level workers who worked as a team, and which then took away some of the burden and spread the burden across these other healthcare workers and other cadre of workers, which, for example, in Kerala, we did come across models where even before the state authorities kind of gave advisories at the local level, when they first heard of the pandemic back in January 2020, even before rest of the state governments took any notice of it, it was the Panchayati Raj institutions and the Panchayati Raj systems at the local level that were actually looking out for returnees from abroad and screening and doing what they were supposed to be doing at the local level before the state itself gave out advisories. Similarly, in the middle of the pandemic in Karnataka, also these rapid response teams were established, which consisted of all these levels of workers, which then spread out both the burden, but also the risks that came with community members attacks and so on and so forth. That seemed like a sort of like a good model. In Andhra, again, there was a system where village level secretaries, which is a new system set up by the government of Andhra Pradesh, they worked along with the Anganwadi and ASHA workers, because remember, it was not just screening or doing just basic COVID-related tasks, but there were other tasks like giving rations to people, making food available to both cooked and uncooked food available, catering to the returnee migrant workers in these states. So all these sort of activities were split between a lot of these sort of workers at the local level, which I think holds lessons for the rest of India as well. Having said that, there are, even in other states, when the migrant workers were returning, it was usually always the sarpanch or the Panchayati Raj members of those states that kind of those villages that were the first point of contact. They were the ones who would send for the ASHA workers or Anganwadi workers or whoever that, here is a set of migrant workers, we need to quarantine them, put them in screening centers and check for their symptoms and all of that. So frankly, with the kind of enormity of the pandemic, only one cadre of workers could not have taken the responsibility of it or the burden of it. And therefore, we do have to learn from some of these systems, especially Kerala and Karnataka, where these, and especially in the coming days when we have both the second wave of the pandemic, but also the vaccination drive that, again, these workers will mostly be handling.
You really brought out a lot of the community perspective and the kind of, I would say, a greater working that emerged between the FLWs and the PRIs. We've seen how active the different, including the elected women representatives were. So I'm just going to go from, the examples that you gave to North India. And I'm going to ask Dr. Sonia, who's also there with us, and she's been managing, this whole in Haryana. So I'm going to, ask, Bhanupriya was talking from the community perspective. And one of the things that she's very strongly brought out is the fact that a lot of the health system also needs to support what the FLWs are doing. So what is it that, have been the lessons from Haryana as you worked over the last 1 year? What is it in terms of from the policy perspective or strategies which worked, which supported the FLWs to perform better in this whole last year to now?
Okay, thank you, Preethi. So I just want to, state at the very outset that it's not just me who's been leading the response. Maybe I've been, on the periphery, because the frontline workers, so be it the ASHAs or the ANMs, they are, in the ambit of NHM because they get their incentives from NHM. In Haryana, it's the NHM that pays them their salary and some incentives. And also the ANMs who remain under, the control of NHMs. And Anganwadi workers, as we all know, they have another department, which is the Department of Women and Child Development. So I've been not directly overseeing or, looking after, but then I know from my other colleagues as to what happened, how was the struggle, which, I'm sure most of the states, would have gone through. Haryana was no different. And I would say that, health systems, wherever they were strong, they were more resilient, and they were able to take the additional burden of this pandemic in a better manner. Haryana, I would say, did well, but of course, the basic, strength of the health system is going to be, it's going to be mimicking the pandemic response as well. So let me just give you, a very, very brief outline of what all happened, which I've gathered from some of my colleagues. So for the frontline workers, especially for the ASHAs and for the ANMs, initially it started with training. So I'm talking about the first wave of the pandemic. So training, of course, I'm sure other states also had the same experience, that the national level trainers trained some state level trainers, and then the state level trainers trained the district level trainers, who further imparted trainings in that cascade manner to the frontline workers. Now here in Haryana, we had like 4 batches of trainings for the state, for the district level people. And initially 20,270 ASHAs got trained. Now they became our pillars for training and educating all the community members in all villages of Haryana, and also in the urban slums, be it regarding the awareness of symptoms and signs, or the hand hygiene, hand washing, the mask mandates, the cough etiquette. So everything related to the COVID pandemic was basically left onto, the frontline workers, for them to go from house to house. And of course, along with this, there were instances where in some districts of Haryana, we had those Tablighi Jamaat people arriving from Delhi, and then they were given this additional responsibility of going from door to door, checking and then again, the lockdown happened simultaneously, actually, and then seeing as to who were the in-migrants and where were they coming from, and checking for the symptoms and signs of influenza-like illness, also comorbidities, so who were the comorbid people, then checking, if they had any symptoms like breathlessness or other things. So these were the girls, these were the women who were going from door to door and conducting all this. And of course, like my other colleague mentioned, that 1,000 rupees per month, of course, was, the additional incentive given, which is peanuts, as compared to the amount of work that these additional work that these frontline workers had to do. But one thing good about Haryana is that Haryana probably is one of those states where Ashas are paid the highest, because we have some additional incentives for 8 additional packages that Ashas get. And Haryana also pays some amount as the base salary. So for even if they don't do anything, they would still get like 4,000 rupees and 25% or like 50% additional of the NHM incentives that they get out of the state budget. So they get 2 different kinds of salaries. One is, of course, the incentive. The other is a salary. So that and the experience in the first wave, of course, like I mentioned, community awareness, which was left onto them. And door-to-door surveys, 6 rounds were conducted. More than 3 crores households were visited during these different 6 rounds. Again, Haryana was no different. Probably in North India, there is, more of, I would say, whether it's like social segregation, so caste or the khap panchayat or the gender, I would say, whether it's segregation or so some discrimination, actually, because, so these ANMs, the ASHA workers, since they are many a time, they are the bahus of the village, it's very difficult for them to talk to a male member. So in Nuh, for example, which is a Muslim-dominated district in Haryana, it's just not done that any woman goes to a man and talks about whatever. And in this case, they had to do that because whether it is mask mandate or how to use a mask or how to wash their hands or how to, how to cough, for example, which was entrusted upon them, it was very difficult for them. There were instances when there was assault, physical assault on our frontline workers by the community. Some FIRs also had to be registered, and then it took some time for the community to accept them better. The new wave is no different. And in fact, Haryana was not different in the sense that we did have some months when our routine immunization suffered, when our institutional deliveries dipped. So then we had to, again, take them on board, also remind them that, okay, for dropouts, we are going to hold special sessions, and they had to do that work as well in addition. In fact, I would say that ANMs and Anganwadi workers were probably lagging behind, but it was Asha, since they were there in the villages, they had to do even more than the ANMs and Anganwadi workers because the other 2 cadre of workers had to travel. And during lockdown, all of them were not able to come to their work station every day. So this is basically the outline of the experience that Haryana had in the beginning. And in fact, Haryana started doing some high-risk identification. Yeah, so we started some mobile testing in which we took some doctors and other members from RBSK, but it was again entrusted upon the ASHAs to identify, to line list people who had ILI-like symptoms, and then they had to ensure that these people were there for the sample collection for RT-PCR. If the mobile team did not visit, these ASHAs were entrusted upon to bring those patients to the nearest health facility for sample collection. So there was a lot of extra work that they had to do. The new wave, again, I would say, is no different, but here, the only difference now is that over the last year, the PRI involvement has improved because in the beginning, it was the community members who were resisting this effort. So like I mentioned, there were 6 rounds of door-to-door survey. The first 3 rounds went on smoothly, but 4th round onwards, there was a lot of resistance because community members thought that these girls were going and giving the names of all these people to the district administration, and then the police people came, pasted stickers, the posters outside their residences. So all of those, like confusions were there. But now I would say in this round, all that resistance is gone. The violence, of course, will not be there. So they are true warriors in the true sense of the word. And over the last 1 year now, they know how to take oxygen saturation, for example. So the home isolation protocols are easy to be followed with the help of our frontline workers. They have the PPE kits. They also have the masks. Whether they get these from the government or they procure it themselves is, I would say that it's not 100% of the times that they would, all the time have adequate stock of PPE with them, but it's much better than what it was in April 2020. And so also, during this time, some of these Ashas who got COVID positive themselves and the ANMs who got COVID positive themselves. So now they know, because they've, I would just say that they are taking precautions. They're also ensuring that community follows a COVID appropriate behavior. So they're the ones who are still doing what our, warriors have to do. So the strategy hasn't changed much. It's just that they know that institutional deliveries, immunization, home-based newborn care, and of course, COVID vaccination. So a lot of additional responsibility is going to be given to them with regard to vaccinating all the community members. And now with the inclusion of more than 18 years, age group people from May 1 onwards, the task is going to be, mountainous, to say the least. And I don't know how they're going to be delivering all this. So now I would say that the male responsibility. So Haryana does have a cadre of male health workers, but traditionally they've been entrusted only with the responsibility of malaria prevention and treatment. So and the cadre is very, very weak. So they're hardly like 350 to 400 male health workers, the multipurpose health workers. But now the thought is that we will be involving them, and especially in those districts where there's a lot of, gender unresponsiveness. So wherever there is the situation that the bahus of the village cannot talk to the elderly gentlemen in the village, the responsibility of going, talking, advocating, ensuring that these people adopt a COVID appropriate behavior is going to be given to these male health workers. So like I mentioned, that the incentives that's good news, that in Haryana we pay one of the highest, maybe it is the highest in the country. So like I mentioned, that the minimum that any of these ASHA worker gets is 9,000 rupees a month, and urban ASHAs get anywhere between 18 to 20,000 rupees a month. And usually these salaries and incentives are paid in time, but there could be some times when there is some bit of a delay. I'm not very sure of that. The GOI's insurance scheme has also been extended to our frontline workers. So God forbid, if there is a casualty, then there is additional cover of 10 lakh rupees, which Haryana government would be giving from their own kitty. So it becomes 50 plus 10, and then 3 lakh ex gratia grant, which is in addition to what they get. So this is how it is. And then another thing that I found out from the Development Panchayat Department in Haryana, that the Panchayati Raj institutions, wherever a panchayat has an annual income of more than 2 lakh rupees, 20,000 rupees can be spent on awareness generation, and it can be done via the ASHAs. If the ASHAs are falling short of any of those supplies, then they can be given through this budget to the ASHAs. But if the panchayat has an annual income of less than 2 lakh rupees, then the Panchayati Raj department from the state headquarters, the Development Panchayat department, would be giving 20,000 rupees to that particular panchayat for awareness generation. So this is in a nutshell what Haryana has been doing. If there's any question or any comment, from any of you, I would be able to address. I'm really sorry that my phone has been ringing continuously, and I might have to go for some other meeting. So looking forward to the clarifications in case you're seeking any. Yeah.
So one, I mean, you certainly shared, the different things that have been put in place. And I also remember that you had shared a set of strategies which were put in place even to ensure safety of the women workforce initially. And now it's kind of ensuring that not only all the COVID and the vaccination challenges happen, but if you could just give a brief comment, maybe just a couple of lines only, but it's more, everybody is concerned on one side about maybe 80% of the work is now to deal with the pandemic issues, and tomorrow it could be another disaster or a crisis. But we certainly do not want our IMR or our MMR or any of that to be affected. So how do you envisage, I mean, from a policy perspective, you have enhanced the capacity, perhaps through the different capacity building training, you provided them digital platforms, etc. So how do you see that in the future, the basic or the most essential health services, how do you see that continuing without getting affected, the other immunizations, etc.?
Yes, so as I mentioned, Preethi, initially there was a substantial dip. So in April 2020 and May 2020, there was a substantial dip in the immunization, also the institutional deliveries, the identification of high-risk pregnancies, and the provision of iron and folic acid tablets to the pregnant women. Everything dipped. But then this realization, in fact, even the medical colleges, the district hospitals, because everybody got so caught up in ensuring that there were COVID isolation beds in the hospitals and that there were, ICUs established for COVID, that even the space which was otherwise available for antenatal wards or the postnatal wards was sometimes being encroached upon by, by making sure that there were isolation beds available in the facility. But then very soon it was realized, and I remember because I was not in NHM. So it was easy for me to understand the pain and the discomfort. So in Haryana, we did this really early. In fact, in the district hospitals, we segregated the COVID areas and the non-COVID areas. And we kind of ensured that the district hospitals at least, and some of the FRUs, they kept on having the provision of essential services. So the deliveries in that sense did not get affected as much. Our problem was the high-risk deliveries because the referral chain got affected and the private hospitals had also shut down. So it was a nightmarish time for 10-15 days when we realized that the Safdarjung Hospital, for example, was refusing patients from Haryana because they were just not able to cope with their own problems. And Haryana, as you know, is surrounded, like Delhi is surrounded by Haryana on 3 sides. So it was very difficult for us to not be able to send any of those, patients from any of those districts to Delhi. And then again, here in Chandigarh, both the medical college in Sector 32 and PGI Chandigarh, they were just not able to take any additional burden from Punjab or Haryana. So then again, we had to build our own capacities to deal with the high risk cases that we were otherwise referring. So it was pretty hard. And although I'm really interested to know as to what additional morbidity, what additional mortality happened during this difficult time, I was not able to. I tried finding out today, but I was not able to find those anecdotal cases. We might have to, go back into the community or facilities to conduct our maternal death and infant death reviews at some point in time because the information is not available as of now. And of course, maybe in the second wave, we now know because all that establishment of COVID and non-COVID blocks in the same hospital, that lesson has been learned. So last month, or maybe for some hospitals, it was earlier this month, all that segregation happened really, really fast. And the routine immunization, we understand that we have to have maybe some camp approach or maybe some other approach to not miss babies like we missed last time. And of course, we conducted some mop-up rounds for the children who had dropped out. But this year, I don't see that happening. The biggest challenge as of now in Haryana is to ensure treatment to COVID positive individuals. So home isolation is still sorted, but provision of treatment at our facilities, like everybody else in the country, we are really struggling. And I'm just keeping my fingers crossed that the situation doesn't worsen any further.
Okay. Thank you so much, Dr. Sonia. And I think, when I would like to just reiterate that, despite all the challenges, I think we've listened to several ideas or strategies which have worked, and, thoughts which have been taken from a futuristic approach to ensure continuity of services on one side, at the same time address the COVID challenge. So let me now go over to Dr. Tanmay. I mean, he's been working as part of the CARE to really, CARE India to really ensure, facilities to the people from a research point studying that. So I would like you to kind of focus on what do you think are some of the positive aspects or positive stories or strategies that worked in terms of how the health system was able to engage the FLWs or build the FLWs capacity? So how do you think the health system was able to do that? Over to you, Dr. Tanmay.
Thank you, Preethi. This is actually a very pertinent question that you asked, because in these trying times, it's very important that we understand that what we learned over these 1.5 years and how are we going to use them while dealing with this second COVID pandemic wave. And we don't know whether a third may also come. So we always talk about management, disaster management, infectious disease disaster management, pandemic response. But preparedness is very important because we don't know what is coming. For that, this particular scare, the kind of omnipresent scare that actually percolated through the whole health system, the providers, the recipient, and everybody related to that, worked in a different way with different population. Like, while talking about the frontline workers, some of our esteemed panel members mentioned the aspects of convergence. We have long struggled regarding having the frontline workers working together. But during managing the COVID response and being on the same boat while managing the worst of the worst, while facing the community resistance, or whether there is some rage attacks, or while dealing with the whole scenario being not always fully protected as they wanted to be, they found themselves on the same boat. They at times resource pooled themselves to divide the workload. They at times tried to use transports together so that one can help other to reach their workplace. And one more interesting story came from the ground, that the maximum help that they actually found from the community to avoid this community response and resistance came only after the time when they started to carry different essential commodities, which not generally came as a top-down approach, the strategy coming down the system. It's kind of the innovation from the ground that different times at different places, there are different things that they were supposed to deliver at the last mile. But because different platforms not being able to work that much, they started carrying IFA tablets, FP commodities, and other stuff along with them, and started to distribute them at the time period when they were actually visiting door to door for the household surveys to understand the contact tracing, travel history, and all of the stuff. While managing the quarantine centers, they also learned a lot, especially their knowledge regarding COVID increased, which I guess is going to be a very important aspect while dealing with this second phase, because last time, all our frontline workers did undergo different kind of COVID training across the country. And those things were being delivered at the time when the recipient of the information was also vulnerable for not following this information. So that's why when at the time when we receive some information, when we feel that it's good to follow them, and we are also advising others, the health belief model is known to work better. And that's why it is always an useful aspect that if this kind of wisdom stays with the system, we can have more informed frontline workers while dealing with this second wave. So the training that was imparted to the frontline workers through different channels, which is another innovation that I'll come to. Together, all these help us to expect that this time, while dealing with confusions and needs, our frontline workers will be a little better prepared, and we have to ensure that it is not little, it's actually quite a lot. And regarding the use of the technology, use of different platforms, getting used to those, not only for delivering their own services, but also receiving information, are found to be very much useful. And interestingly enough, based on the series of studies that we have conducted in our place, we actually found the statewide surveys actually indicated towards the fact that interaction with the supervisors was the most important and influential positive point for them to have better service delivery as well as better motivation. One of the biggest problem of our frontline worker system is the lack of self-recognition and lack of the community appreciation. Our esteemed panel member were talking about the problems that they need to face, some of which are actually gender-based also. Basically, the fact is that being a woman while dealing with maternal and child health, the amount of self-recognition and pride they should actually have within themselves, that was somehow missing after years and decades of engagement with the system by them. But this current engagement in the COVID response, I guess, brought them much closer to the community. Initially, response, Corona Didi, etc. But later on, gradually, I guess, there was always an understanding that the community response need to build on those frontline workers' linkage services, as well as the community reaction that already spoken to with the PRI members and others. One more positive point that I would like to mention is the awareness building system. That is, we always know that we use media, we use all other printed and electronic media and all other channels, but the self-help groups and these frontline workers channels are potentially very strong and useful media to spread awareness regarding the COVID appropriate behavior, as well as, I guess this is the way forward basically, regarding we have moved from everybody getting admitted plan to the home isolation plan. Now, how to manage the biomedical waste at home when we are having home isolated COVID patients, when we are having majority of the mild patients being actually at home, how to actually handle situations and identify emergency alarms when somebody needs to basically go to an institute where the close monitoring may be much better than at home. This kind of aspects are very much required to be transmitted to the community. And for that, health system needs to make the use of these resilient frontline workers whose resilience, I guess, increased quite a lot after having this fight of more than 1.5 years. And based on all our study, we have understood that interaction with supervisor facing different kind of challenges, getting more and more training, receiving protective gears and years of experience are potential strong predictors of providing better services, being knowledgeable. Together, if the system can work on these and develop champions in the community who can actually guide the community to have the right people at the right place while being either isolated at home or being admitted in the hospital, I guess the current scenario of not having any bed anywhere, I can give a very simple example. Just being prone helps a lot of oxygen consumption, oxygen cylinder and oxygen consumption reduced. The oxygen saturation for a COVID patient, and whatever I'm mentioning this right now is much of that are personal. It's actually being just prone one person actually taken away from an urgent feeling that I need oxygen to not requiring that at the early milder stage of COVID. So these kind of prone positions can well be taught to the community through simple mechanism using our frontline worker channels and other stuff, as well as the kind of nutrition that the community needs at the time of this kind of pandemic, the kind of things that need to be avoided, the kind of ventilation a room should have to avoid the kind of recirculation of the virus and all this stuff, and avoid all kinds of meats and other stuff. I guess our frontline workers are the mainstay of those work, and we have to be better prepared for that. Risk communication is a very important science and of which we are not very much trained of. So I think let us actually go ahead and help our community workers, community health workers, to be a better risk communicator to our community. Thank you.
Thank you, Dr. Tanmay. I mean, I think that's very well said. I mean, it's not just risk communicator, risk identifier. From there itself, it starts. So Bhanupriya, as you listen to all of this, and you started out by talking about the need to actually, through your evidence to kind of amplify the whole voices or the needs or the issues of concern or challenges of the FLWs. So the question in this round, which I would like to ask you is, see, we're grappling with one side, the whole addressing the whole COVID and the vaccination challenge. The other side, we are also looking at long-term health system capacity building or strengthening. Where do you see the FLWs fitting in terms of how do you further amplify their voices so that suggestion, because they actually know at the ground level what change needs to happen. So how do we have a mechanism of constantly listening to their suggestions and having it go all the way upward? Or what is your recommendation of how the voices of the FLWs can be better amplified so that actually what needs to change at the ground level really goes up, and then added with evidence such as what your research is bringing, that brings in the evidence as well besides what they are saying. So how do you see this happening in a more sustainable manner to really strengthen our health system bottom up?
I think I will again say from what I started my talk with, and that is that unless the system considers healthcare workers, the frontline healthcare workers, and in this case, the ASHA workers specifically, and I'm not talking about Anganwadi workers because they don't come under the Ministry of Health and Family Welfare, as Dr. Sonia was pointing out, or auxiliary nurse midwives, because they are essentially, they are workers of the healthcare system. Who is precarious here really is the ASHA worker. And I will once again reiterate that when we look at the sustainability or the strength or the robustness of a healthcare system, if we are not looking at it from the point of view of its most frontline healthcare workers and a female healthcare worker at that, then we are failing and we are not learning our lessons. And what I would want to say at this point is essentially what healthcare workers have been saying for years now, and nobody has been listening. And in that sense, I would say the pandemic has really brought their voices in some ways to the fore. They're able to now, even when they do dharnas and protests and amplify the voices, somebody is listening to them. And it is not me, it is their voices themselves that are saying that for years, they have demanded that they be considered an equal part, an equal stakeholder in the healthcare system, by which what they mean is that they be considered full-time workers. At the moment, they are what is called accredited social healthcare activists. So they're not workers. They do not get a fixed salary, except in some states, as Dr. Sonia was mentioning. Haryana is one of the few states that gives a fixed salary. Although it is not the state that gives the highest salary, that would be Andhra Pradesh, which gives 10,000 rupees of fixed salary to its healthcare workers. But Haryana is one of the states, one of the 6 states only in India that gives a fixed salary to its healthcare workers. So what have the healthcare workers been demanding all these years is that they be treated as a class 4 employee at least, with a minimum salary of 18,000 to 24,000 rupees and social security benefits. At the moment, the ASHA workers do not get, neither get insurance, and we're not talking about the Pradhan Mantri Kalyan Yojana of 50 lakh insurance during the COVID, but a normal insurance program, they're not part of that. They do not get maternity benefits. They do not get pensions, actually. So just recently, healthcare workers in Haryana were one day told, do not come to work from tomorrow onwards, and there will be no pension for you. So if we are not tackling these systemic challenges, and so essentially then we are not looking at frontline healthcare workers as part of the system. And as far from where I come from, having worked with and also sort of talked to 250 healthcare workers across India, 16 states in India, this is what I can say, and very categorically, that unless we consider them as workers with rights and benefits, and along with which comes the question of then respect from within the healthcare system. To be honest, actually they have quite a lot of respect from within the community. A lot of ASHA workers have told me, and very categorically have told me that, it is the community and the love and respect that they have for us, because they've really been working from within the community system, not just during this pandemic, but even before that, right? For all your maternal, childcare, health services, etc. So what they have repeatedly said to me is that it is the community, and it is because of them that we are actually do not want to quit our jobs. But really, if you look at the way the system treats us, or in terms of the paltry salaries or paltry incentives, or lack of benefits and lack of respect. Let's not forget, when we talk about systems, the basic requirement of any human or any worker is a minimum sense of respect. And if you're holding an entire healthcare system on your shoulders and the system does not respect you for it, then it becomes really problematic, and no kind of I would think that no kind of long-term solution can be thought about if we are not thinking about rights and the kind of respect that comes with it. For example, they are now in the middle of a vaccination drive. And if ASHA workers are, their incentives are driven by tasks, have we asked the government that what is the incentive, extra incentive that ASHA workers will be paid for these vaccinations, right? That question has still not come up to the government, and we should collectively ask that question of the government, and so on. So either we talk about and it's not an either or at the moment, until we set up these long-term systems in place where rights are inherent part of them. We should be talking about every sort of activity that needs to be paid for, and paid for in a just manner, because what the kind of work that ASHA workers or Anganwadi workers, thankfully Anganwadi workers are still paid a fixed salary, not enough, but fixed, at least it's fixed. For ASHA workers, there's no fixed salary. So if we are going to be talking about long-term sustainability, then we have to embed the question of the rights of these workers first. On whom rests this whole both pandemic response and pre-pandemic sort of carrying the burden of the healthcare system as well.
I think you kind of very nicely brought out, like in the beginning when ASHAs and all were just introduced, they did a lot of work just to get that community acceptance, have their families allow them to go out, do the work. And like you mentioned, today, they've earned that respect in the community. And that's probably the biggest incentive that keeps them going, no matter the fact that like you're saying, the other things for which people normally work for, your basic bread and butter, if that is not there, it's just the respect of the community and the recognition and the appreciation that they get of the community members that they help out that keeps them going. But you also brought out the importance of systemic needs that must also be in place. I mean, this is okay for perhaps one generation of that group, but for continuity for the next generation and all to take up and continue working in this spirit, missionary spirit lasts only so long. So I think at this point, I'm just going to go to Tanmay and just Dr. Tanmay, if you could respond on this issue of if the health system had to engage FLWs, had to engage or further capacity building or for strengthening the health system, because Dr. Sonia was also mentioning the referral system kind of got disturbed in the COVID challenge. On another hand, with the PRIs and all that, we are seeing that there is a stronger, I would say in one sense, a group at the community. And Dr. Tanmay, earlier you talked about resource pooling, how different groups are coming together. So would you like to share your thoughts on how you feel going forward from a system perspective, from a health system perspective? How can the health system further either engage this FLWs in a better manner, or what can they do to empower? I'm not telling in terms of giving them additional responsibilities, but really enabling what can the health system really do in order to make the FLWs, truly their work far, far easier?
This is a very important question that you asked, and actually there is a requirement of quite a lot of work to ensure this, because frontline workers are always overburdened with all kind of stuff that needs to be at the ground level, needs to happen at the ground level. They are considered to be the best researchers on the earth, best data collectors, best community communicators and everything. But majority of the training that they receive, those are actually basically in terms of delivering those at the ground level, not really generating their awareness or the system response and other stuff that needs to be elicited in a certain situation. Now, first of all, frontline workers need to give them some more power to have a rational avenue of prioritization. It's always there, always what they generally do. They receive a lot of orders. They try to follow them. Some of them are smart enough who could actually identify a process of bypassing the whole process and getting the incentive. And the others who are actually not there with doing that work. Now, the point is some of the amount of the work are not really feasible in terms of the total amount of things to be done. So there is always a requirement of a prioritization. And the prioritization needs to change depending on the situation. Just like when this second wave is going on, there will be a different type of requirement in terms of resource pooling I mentioned, in terms of organizing different service delivery points, smaller in number, but more closer to the community, etc., etc. On the other hand, there will be requirement of generating the services to a more organic way into the community to identify situation, identify the more more affected cases and identifying different community needs. So for that, it is very much required that the self-recognition and that empowerment of allowance of doing some prioritization through supportive supervision, not prescriptive, is very much required. If the health system can actually have the monitoring and supervision of the frontline workers more supportive in terms of they will be providing them the necessary capacity building and knowledge as required, as well as supplies being adequate. Whereas frontline workers using their wisdom, they know their community much better than the next level of the staff. So they should actually use that wisdom to actually deal with their community, because ultimately it's their catchment area. it is also required that frontline workers selection and training and their onboarding, this whole process needs to be made streamlined in different states, so that wherever there is a gap in terms of getting them into right work at right time after right training, it should be actually bridged right now. And their own motivation, resilience, and mental health aspects. Somebody, there was a question in the chat, and I actually wanted to answer
I
that
was
live.
just going to say that if you could answer that, Rishabh Sachdeva was asking about the mental health for the frontline. So please go ahead and answer that.
Yeah, so this is very much important to work on the resilience, well-being, problem-solving, self-efficacy of our frontline workers, just to name a few. There are several efforts going on currently in Bihar. Also, one such process is going on. We hope that the result of this pilot will someday be scaled to the national level. So what I'm trying to say that the mental health as well as the resilience of the frontline workers need to be built in such a way. And after that, they should be given proper allowance that together, being more motivated and being more goal-oriented, they can actually prioritize what they should need to address more and do that in a more organic way. Other aspects of payment regularization, etc., we have discussed a lot. But ultimately, when we have an ASHA type of cadre, it's also the social equity, it's also the social return that we need to keep in mind. And for that, we need to make our frontline workers enough prepared.
Thank you. There's another question from the audience, Manisha Bhatnagar, who has asked, would like to know what kind of training or hand-holding support is available or should be there for the ASHAs with respect to vaccine awareness, its side effect in the current scenario, managing and supporting. Bhanupriya, could I request you to respond to that in terms of vaccine awareness, what kind of support is required?
Yeah, so I think, I'm honestly, in terms of what kind of support is required, the reports that are coming in to me, and we are in the process of sort of finding out more about what ASHA workers' role in the vaccination process is and so on. What we are finding, the initial reports that we are getting is that that ASHA workers are now being given targets to mobilize members of the community to come for their vaccination. In fact, I've seen videos that ASHA workers have forwarded me who, who are going in the streets within villages and hollering out, asking people to come out for the vaccination and so on. In terms of what sort of trainings they have got yet, I am not really aware of the kind of trainings they have received from the government, and if so, or what sort. But if the first wave of the pandemic is anything to go by, and how they were left to their own devices to be able to explain what precautions, what COVID is, or what precautions need to be taken and so on, I think in this round of vaccinations that I do hope that governments have given some sort of directives and communication protocols to a community member, to ASHA workers to deal with community members. So I'm not really aware what is happening on the ground in terms of the actual explanation of what the vaccine is and how it needs to be sort of what are the precautions and why the vaccine in the first place. But going by some levels of vaccine hesitancy itself on the ground, the reports that we are hearing, there seems to be a lot more that needs to be done, and ASHA workers are best placed really as part of the community to sort of give this message of why the vaccine and the efficacy of the vaccine and so on and so forth. But here is the thing I would really like to flag again, and that we are hearing of cases where targets are being set and threats are being given to ASHA workers. Really, that if you do not meet the targets, your incentives will be cut off. Now, this is exactly throwing back to that coercive mechanism, which really doesn't bode well. It's sort of, governments really need to, systems really need to sort of engage with health workers more rather than use this kind of coercive language. And these are reports that we are hearing from ASHA workers across multiple states already. So, and in some of the states, when we wanted to find out whether actually some sort of incentives were cut on not meeting the targets, we found that their incentives have not been paid for a few months now. So we really don't know. But that's something we will strongly be monitoring. And that is a good question in terms of, it's something that we would be monitoring again about the kind of trainings that ASHA workers and other community health workers have been receiving on administering the vaccine or communicating the efficacy and the need for the vaccine.
Okay, so I think, to kind of wrap up the session, because on one side, Dr. Tanmay is also writing up responses. I would probably just ask you first, Bhanupriya, and then go over to Dr. Tanmay. But there are a lot of issues which have come up in this webinar. There are a lot of discourses happening on social media, Twitter chat, everywhere. What is one critical component that you feel is missing and that really needs to be there if we are truly, to help the FLWs?
Yeah, I think actually, I think in terms of the, and I come from a purely FLW perspective, and not so much from the systemic perspective as Dr. Tanmay and Dr. Sonia are. And from the community frontline health workers perspective, I think what, as I said before, what we've seen now is this question of the their wages and salaries and the work burden that they are having to put into quite amplified quite a lot. The question that really, I think, has two things that have been missing in the current conversations during the pandemic is, I think it came up right now on the mental health of frontline health workers. And we found out in our study that we did across 10 states that mental health of health workers is really, really under stress. And it's not just mental health, it's also the family dynamic, which we completely miss out when we talk about, healthcare workers or any system level workers with the burden that of work of COVID, and as well as and lack of their salaries and incentives, etc., or the monetary burden on their families. What we've seen is a large rise in domestic violence among health workers. This is something we found in our study, which is very concerning, because healthcare workers, ASHA workers have had to constantly be out, and and so with their male members not working at that time because they've lost their jobs, or during the lockdown, and after that the economic situation has been grim. What we found is that the entire burden fell on the ASHA workers, but at the same time, with all of these also come the questions of violence, etc., which have risen quite a bit. And the absence of a complete support system, of a state or institutional support system for these healthcare workers. Now, having one stray supervisor or an A&M talk nicely to you is really not a systemic response. It is a very interpersonal response that two people develop among each other. So we need to think about larger systems of institutional response to the mental health crisis of stress, burden, which is also manifest in the physical. We've heard of ASHA workers complaining to us about severe back pains and knee pains, arthritis, and so on and so forth. The other critical question, and I hope we start talking about it in the absence of a full-time wage at the moment, is what is the incentive for vaccination for these healthcare workers, and henceforth insurance for not just ASHA workers, but who are covered under the Pradhan Mantri Garib Kalyan Yojana, but Anganwadi workers who are also equally participating in the COVID drive. So yes, they don't come under the Ministry of Health and Family Welfare, but they are providing critical services and are part of the same system that is responding to the COVID crisis. So we need to talk about a couple of about the role of Anganwadi workers and their incentives for them, and the incentives for vaccination for ASHA workers.
Dr. Tanmay,
yeah,
what do you
yeah, very good points that Dr. Bhanupriya mentioned. I just want to add that we need to ask ourselves and the system, how could we make our frontline workers proud of their work? They need to feel proud. There should be enough community appreciation to have self-recognition and pride for them, because gradually we are heading towards a situation when there was a question also in the chat for Dr. Bhanupriya that why is this actually like this regarding frontline workers? This is just because we just kept them as a linkage worker. But we need to know at places where doctors are not available, frontline workers include A&M also, and A&M are the main deliverers in the facility, in the labor rooms. ASHA workers are the main treatment provider in many places where they can. So they should feel proud about their work. There is a requirement of having the whole system's accountability towards making them feel proud and recognized. Their self-recognition can really help us to have a motivated frontline worker.
Thank you so much. I'm just going to take a few minutes to summarize the discussion that we've had. Listening to the panelists, there are several areas that they've highlighted in different ways, which just need to be amplified with the hope that it will soon get realized. Just mulling over what we've been listening to over the last 1.5 years. We've certainly listened to the fact that right from the context setting onwards, there's no denial that today, whatever we are able to manage in COVID, at the end of the day, the last mile credit goes totally to our frontline workers. And they have become very essential peg for the health system's COVID management. And that is so important. And we just need to keep acknowledging and really appreciating the services that they are doing, despite the fact that they are doing this underpaid, overworked, and yet they are that critical bridge between the community and the health system. And we've listened to how they've even had to do perhaps some certain clinical tasks. Maybe it's monitoring oxygen levels, carrying basic kits, some of which they get the training only after they have been doing for some time, or some they just manage on their own by asking on their own to different people. We also listened to the fact that, if we were studying, we study something called Maslow's hierarchy, motivation. And the basic needs, along with salaries and incentives, all of that, it's not there in place. And even if it is in place, it's only in some places, but not everywhere. So how does this transition of what we are calling as our foot soldiers, COVID warriors, the most important peg, how do we make them a reality of being truly an employee of the health system? They have been addressing on their own several huge personnel challenges, short of supplies sometimes, whether it's PPE, inadequate drugs or supplies, whether there is hope for that salary or continued incentives or even a pension support. Sometimes it's even delayed payments or incentives where it is there, which kind of truly impacts on their mental health and their functioning within the health system and within their own family. We've also heard how different states have reacted, and we've heard several positive adaptations, strategies which have really worked, We've listened to how Haryana has kind of looked forward and very early on identified the fact that the essential services of the health system cannot be compromised when COVID challenges also being met. So how they have learned from that experience. They also have a hybrid payment model in place to look after their health workers. So as we listen to experience in Bihar, or even from the research study, which is spanning literally pan-India of the voices of the health workers, there's a lot of scope for cross-learning. And we're also hearing the amount of convergence that is required from different government functionaries at the ground level, be it the FLWs, the PRIs, or other SHGs, etc., which could really strengthen the community response and particularly support what the FLWs are doing. And so we need to look at solutions, the positive adaptations on how to integrate them organically at the state level. But yet, as we look at all these challenges, it is also equally important not to forget the people who are actually doing this and their needs. And therefore, if there could be, at the end of this webinar, maybe three recommendations that the panelists would have voiced, it would probably be, we're talking about long-term sustainability. Capacity of the health system, certainly to be resilient, not only in regular time to achieve universal health coverage or sustainable development goals, but also at the same time to ensure the people who are providing the services, they are valued, they're respected, and they are given their rights as they are demanding, which is just a fair. And not only that, how can this entire ecosystem ensure that their health needs are also looked after, be it on the health insurance part, be it on their accessing of different healthcare needs, or it is accessing resources that they need to carry out their work. We also listen to how transfer more power to them in terms of prioritizing or supportive supervision, how it is vital, and organizing their workload, especially from this prioritization perspective, supportive supervision could help. And support in terms of mental psychosocial aspects, that would also help to ensure social equity and motivate them to continue their work effectively. The third recommendation would be in terms of the health system, the need to kind of have capacity building and engagement process very much in place right from day one. The whole onboarding or the orientation from that perspective, or the need for regular refresher training. So when anything new is cast on them, it must be preceded with a training and not necessarily, and not the target approach. The idea is empower them with the knowledge or with the information so that they can help others in the community take informed decisions. If these are, I would say, like the three really strong recommendations that we can make. And then if this could get amplified further, let us hope that the pandemic, among all the negative aspects which are out there, if it has helped to bring about recognition of these people who just keep working in every part of India, in one sense behind the scene, let us hope this spotlight which is now thrown on them, the increased attention to them, will also amplify their needs and ensure that is also met alongside, while we pray for everybody to be safe, be socially distant, and let us all join together so that our country is free of COVID. And then we are also able to address whether it's the vaccination challenge or ensuring that we are able to look after each other in terms of the needs of healthcare. As I conclude this session, I would just like to very quickly acknowledge there have been so many people who we need to thank in front, at the back. The panelists who from their busy time gave their time and been here. Thank you so much. We would also like to acknowledge support from the co-anchor Oxford Policy Management in conceptualizing the session. We'd also like to thank CoordNet community for sharing their resources. Thank you so much.
Great, and a big thank you to you, Dr. Preethi, for kindly moderating this and holding all of this rich conversation together. I'd also like to share with you that over tomorrow, as well as the next week on Thursday and Friday, there's many more conversations that we will have with other members of the CoordNet community. So please do join us for that. You can find details on SHED. Tomorrow, there are two showcases. There's Swasti Health Catalyst that talks about particularly HIV positive communities and what COVID-19 did for them and how bad it was for them. C3 talks about the evolving impact of gender norms based on a study they did with women politicians in Bihar, which is super interesting. We have two dialogues with Indus Action talking about action research, as well as Janagraha and an IPS officer from Assam talking about pandemic policing and what social innovations happen in that space. And then later on in the evening at 4 o'clock, we have a plenary on nutrition and food security with Dr. Divya Nair from ID Insight, Dr. Purnima Menon from IFPRI, but as also representatives from the World Food Programme, the Hunger Watch Survey, as well as the Nutrition Coalition. And then later in the evening at 6 o'clock, there's a panel on the impacts of COVID-19 on family planning and SRH services with C3, DKT India, IPAS, ICRW, as well as the UP TSU. So there's quite a bit that we also want to do tomorrow. And to suggest that next week there is a bunch of programming, so keep an eye out on your email and so on. You can see more details on coordnet.in and follow us on Twitter. And finally, if there's many of you who are researchers and are not part of the community, do write to us at hello@coordnet.in, and we'd be able to share with you more. We are an active community on Slack, and we'll onboard you, etc. So thanks again so much, everyone.